This podcast is brought to you by the North Dakota Petroleum Foundation. From heating our homes and powering our vehicles to cell phones, clothing, and medical equipment, oil and natural gas makes everyday life better. North Dakota Oil and Natural Gas, advancing the possibilities. Learn more at ndpetroleumfoundation.org. Plain Talk Podcast. I'm your host, Rob Port. Hey, before we get started, I'm going to be talking with Insurance Commissioner John Godfread here in a minute. You probably saw headlines about a big, fat golden parachute that a Sanford CEO got, and what impact that might have. In fact, you know that has an impact on your healthcare prices, and the price of everything is going up. So anyway, we're going to talk a little bit about that in a moment. But before I begin, first of all, I want to say thank you to all you listeners out there. Every episode of this show is now getting thousands of downloads, which is fantastic. I notice a lot of the downloads are coming from people who are listening by way of a browser. I know I put the audio on sayanythingblog.com. The audio is available in my columns on inforum.com or the Grand Forks Herald or what have you. If you want a more convenient way of listening, you can download the show through your favorite podcasting service. So Spotify, Pocket Casts, Audible, there's a lot of them out there. Pick the one. The Plain Talk should be available through that service. If you're having any problems, feel free to contact me directly. That's rport@forumcom.com and download. But again, thank you for everybody who's been downloading. Lots of downloads. It's really been a lot of fun to do this show for you. So anyway, now to my guest, John Godfread, Insurance Commissioner. Mr. Godfread, how are you?
I'm doing well. Thanks for having me, Rob.
I'm going to read from your press release that you sent out because we got news that former CEO of Sanford, Mr. Krabbenhoft, am I saying his last name right?
It's Krabbenhoft.
Krabbenhoft, that's right. Mr. Krabbenhoft got $49 million. Now, he was let go during the pandemic because he made some comments about masking or whatever that the hospital didn't like. That's whatever. The whole masking debate is what it is. That's not what we're here to discuss today. What we're here to discuss is him getting $49 million to basically go away. This is what Insurance Commissioner Godfread said in his press release. I quote, "I understand and respect the right of private nonprofit hospitals to make their own financial decisions. To that end, Sanford Hospital has long held the highest executive and physician pay among its North Dakota competitors. We highlighted in our healthcare cost study," and then you link to the study. It goes, "At the same time, Sanford also had a steady decline of financial assistance to our consumers who need it most. These financial decisions do not happen in a vacuum and have dynamic impacts on the consumers in our region." John, give us the highlight. What's going on here?
Well, I think we've always had a discussion going around the cost of health insurance, right? And the cost of health insurance is increasing. You know, we can go back to 2010 when the ACA was passed. We saw some dramatic increases there. We've seen another number of different increases across all of health insurance, right? And for a long time, I would argue even prior to 2010 that we've been really focusing on the insurance companies and talking about how do we narrow that down? How do we clean that up? How do we make sure that they're not, doing things unfairly or charging too much? And I think one big piece of this discussion that we haven't been talking about is the cost of healthcare delivery. So if the cost of my healthcare is going up, my health insurance is inevitably going to go up. It's the same thing as if I buy a 2008 Ford pickup versus a 2021 Ford pickup, my car insurance is going to be more because the thing that I'm insuring costs more. And so we need to have an honest discussion with, I'd say, both sides of that coin if we really want to talk about how do we lower the cost of healthcare. And 2 years ago, the legislature authorized my office to do a pretty monumental study, a healthcare cost study. I think it's the first one of its kind in the country where we actually got to look into the hospital's books, and they're required to give us data on their financial side of the world. And I'll tell you that it was about a 18-month study. The really unfortunate thing is we released it right at the beginning of the pandemic. That's when we kind of wrapped up the study. So it was really hard to have a hospital study coming out right during a global pandemic. But it still doesn't take away, there's some important data points in there. There's some important things in there. And when you look at where North Dakota stacks up across the country, we're near the top in a lot of the areas you don't want to be the top in, which is hospital expense, hospital revenue, utilization, inpatient stays, all the different things that you don't want to be at the top of if you're a healthcare system. And so I think we've had some ongoing discussions, and I'll tell you, it's not just Sanford. This is more of a hospital system problem. But when we released this study, rather than coming to the table and sitting and talking about how do we solve these problems, I would argue the hospital and through their associations were basically more interested in discrediting the study. And that's pretty disappointing to me, because these were their numbers. We took the numbers from them and verified them against other publicly available data, and the numbers show what they show. And I don't think it was never intended to be a stick in the eye anywhere, but it's meant to be, how do we solve this problem? Because we're on a trajectory that's unsustainable. And then so you go through that kind of fight where they're saying, these numbers don't make sense, and we've got a lot of different reasons. And one, the hospital association representative actually stood up in front of a legislative committee and said, we should all be proud that we're paying more because we've got great quality. And that's demonstrably false, right? I mean, you can make that argument you want, but when you look at our quality, we have fine quality, but it's not like we're shooting out of the stratosphere on quality.
I don't feel like I don't feel like I'm, if I go to a hospital in North Dakota, I'm getting better care than in South Dakota.
Exactly.
I say that the care's fine. I mean, I spent 10 days in the hospital with COVID at Trinity Hospital. I felt like I got fantastic care. I felt like they did a really good job, but I don't know that. I don't know that it's any better than anywhere else.
I'd argue the amount that we're paying more versus the difference in quality isn't, that's not a reason to stand up and say, hey, we should all be proud that it costs more in North Dakota to receive healthcare than just about anywhere else. And that's to me is really, really scary. And then you layer that into the legislative discussions that we've had, especially around Medicaid expansion. And I'm not an expert in Medicaid expansion. I'm not an expert in the Medicare rates or Medicaid rates. That's Chris Jones. But for the last 3 sessions, we've had a discussion downstairs about, do we go from commercial rates, which we pay in North Dakota for Medicaid expansion population, back down to traditional Medicaid rates? From what I understand, that's about a $200 million hit to the hospital system if the state were to say we're gonna go down to traditional rates, and so it's a $200 million savings to the state, but it comes out of the hospital system, and the hospital systems downstairs will. I mean, it is, the sky is falling. We're going to have to close doors. We're going to have to, everything's going to be terrible. And then you see the news that broke last weekend where there's essentially $75 million in payouts to executives at Sanford. That just doesn't jive with me. It doesn't make sense. And so every time we've gotten into discussions with hospitals, it's about what we can do on the system. Their answer has been, we need more. We just need more. And I've had them in my office here talking about how our health insurance companies have got to give us more money. The reimbursements have got to go up, John. You got to make this work. And my response to them is, if we increase their reimbursements, premiums go up. And I'd say I think you can make the argument that our consumers are almost tapped out, if not already tapped out on premium increases.
Well, especially everything else that's going on in the world right now. I mean,
and
price
so
of food's
it's
going
like
up.
we can't get more out of this. And the really scary thing to me, Rob, is that I don't think the hospitals are acknowledging this quite yet or enough yet, where by not really coming to the table and not really looking at how do we redefine our delivery of healthcare. I think we've got the opportunity to do that in North Dakota. We've got a good legislature. We've got a governor who I think is on board. You've got an insurance commissioner who's absolutely on board. We're small enough, I think, and nimble enough to make some changes. We could change how we do healthcare and be a leader in the country. But again, every time we come to the table, it's what we simply need more. And my argument is, I think we're on a track to, if more is the only answer, that means premiums go up. That means, the cost of healthcare goes up. So we're eventually going to reach a point where it's going to be a single payer system, because the consumers are, you're already seeing it on the individual market. The Biden administration has expanded subsidies dramatically. And so again, the federal government stepping in saying we can provide this health care. And I don't think the hospitals want to be there either, because if you do that, that's Medicare rates for everybody, and they're the last
price
ones that
controls.
want that.
And I don't want price controls either.
No.
Now in a free market, there's price controls, but they're a function of the market. So if I'm manufacturing a car, an automobile, I could do everything. I could have everything gold plated but it's going to cost hundreds of thousands of dollars to buy my car. The market for that sort of a car is very small. So if I want to sell more cars, I have to find some equilibrium between, the car I'm offering versus what people are going to be willing to pay, right? That's the price control that's inherent in the market. If you charge too much, people just aren't going to buy it. Now, the problem is in the insurance industry and the healthcare industry, it's almost like, I look at it almost like higher education. Like if you look at the two costs in our economy that have sort of tracked each other and have soared high above every other cost that you pay in your household, food, housing, clothing, everything else, the two that are is higher education and healthcare. Healthcare/health insurance, because that's how we pay for it. And I think the reason is they're both part of the same problem. Whereas in higher education, we've essentially made it so that anybody can get a higher ed loan, right? Anybody. The government's, it's just you're there, you get it. And so the colleges have begun charging more, not because they have to, but because they can. They can get away with it. We have created, but by the government basically turning higher ed loans, student loans, into essentially an entitlement where if you want one, you get one. The colleges can just charge basically whatever they want. And we've done that in a lot of ways with healthcare. The hospitals can kind of, we all know the notorious stories, $30 for a Tylenol and all the, ridiculous stories. And they're getting away with it because of the way it's structured. They're not really charging me. They're charging my insurance company, and I'm not even really the customer for my insurance company. I like most people, I get my insurance through my employer, right? And why wouldn't I? That's a good deal for me, and I actually feel like I have great insurance, but the disconnect there in the cost is what's enabling all of this, and I don't know how we put that back so that this market can function like every other market where we don't have to come in and say, hey, hospitals, you're getting carried away with what you're paying your executives.
Yeah, no, and I absolutely agree. It's if I'm a hospital, I like this arrangement, right? So you come in and receive services, you have no idea what those services are going to cost. And we did a secret shopper in our healthcare cost study, and we looked at a traditional birth, a cesarean, a C-section birth, and a colonoscopy. We did 3 kind of common procedures. And we called each of our 9 major hospitals and said, what's it going to cost me to do this? And I'll tell you, it was almost impossible to figure that out. And eventually we'd get a letter back with no contact information, no nothing, just saying, here's your price. And the variances between what it costs in Minot versus what it costs in Fargo, what it costs in Grand Forks versus what it costs in Dickinson are astronomical.
Which is indicative that the price is not really based on what it costs, right? Because if you're buying a hamburger, you're going to see some price variation from place to place, because there's, the McDonald's hamburger is maybe not the same thing as it's definitely not the same thing as a steakhouse hamburger, but for the most part, you can probably guess what the price of a hamburger is going to be no matter where you go. You should be able to do it with something like a colonoscopy, which is a very routine procedure. But you can't, because the price isn't based on the reality, the cost of providing the service.
So and so that again, so you go into the hospital, they're going to charge you whatever you're going to charge you, and you don't even know, and I'd argue you have a hard time even figuring out. If you wanted to know, you wouldn't be able to figure that out. And so you get charged, you get the bill from your insurance company, you end up getting mad at your insurance company if you're engaged like that, and oftentimes you just pay the copay and you move on with your day and do whatever you need to do. But they are very, very insulated from this whole price discussion, and it's by design, right? It's intentional. And if I'm a hospital, I'm going to continue to fight for that insulation, because the consumers are mad at the insurance companies. We get to stand up and say we're providing great care, and in North Dakota they generally are. But without having to engage in the price discussion, I'll tell you, it's not a problem only here in North Dakota. It's nationally. Sure. I chair our health insurance committee at the national committee, or national association, and we called in the National Board of Hospital Association to talk about patient billing and talk about the No Surprises Act that's coming into effect in January. That's probably a whole nother story. But their response to us was, we're concerned about patient care. And it's like, okay, but I would argue a pretty big piece of patient care is not putting them into financial bankruptcy the minute they walk out your doors. And gone are the days of, well, we don't deal with billing. We're here to save lives and make sure that the patients get what they want. But we can't, you can't ask us to look at the billing. And it's like, well, you're a hospital association, so I'm not asking the frontline doctors to be up on the codes, but
right. So somebody at the hospital deals with billing, because I get bills from them.
Oh yeah,
so.
But it's weighing that through and what's reasonable, what's appropriate.
I like that excuse, like the heart doctors, like when he's done with the heart, he like goes into another little room and starts doing the invoice up, right? Like I don't think it works like that, fellas.
No. So it's a system that is in need of some changes. And again, I think that's why we did the study, and that's why the legislature authorized us to do this study, was to incentivize people to come to the table and let's talk it out. But again, the minute we've shown that we've sit around the table, I'd say our hospitals put their arms around their chest and say, there's nothing we can do to lower our costs. We are rate takers. We don't, the government sets our rates, health insurance sets our rates, and there's nothing that we can do to help levy this. And that, again, the government, Medicare, Medicaid rates are set, absolutely, but the private market, in the last 8 years, we've seen an increase of about 30% in reimbursements. And so my argument back to the hospital is there is negotiation happening there. There is things happening there if we're seeing a 30% increase over 8 years. And so you can't just say you're a rate taker. And because there is negotiation. Sure, you're probably not as much of a rate setter as you'd like to be on the private side of the world, but that's because there's other partners in there that you've got to negotiate with. And coming to the table, crossing your arms and saying there's nothing we can do, the insurance company's just got to give us more, is not how we start a conversation. Yeah. And so I actually got to have a good conversation with Bill Gasson, the Sanford CEO, on it would have been on Wednesday, and we talked through some of this. And I'm hopeful that out of all this, and again, those payouts were contractually obligated. I understand that, and there's things that they had to do to do it.
But they also signed the contracts to begin with.
Oh yeah, no, and I made that point. I said, entering the bad contracts isn't an excuse. But my point was, I think more along the lines of, I think the days of the hospitals coming to the North Dakota legislature asking for more, I said that argument has got to be done now, and we've got to really look at how do we adjust our system and how can we all work together to figure this out. And I'm hopeful that we can do that, but. Yeah. This is a big day a big moment for us, because again, we're getting over that initial hurdle of it just takes more money.
And again, this is not a class war issue. This is not about, we're upset because some CEO makes a lot of money. I'm fine with doctors making a lot of money. I'm fine with CEOs making a lot of money. Those are very complicated jobs. They take a degree of expertise. I'm not a heart surgeon. Heart surgeons should make a lot of money, but and every other medical professional. So I am fine with all that. The problem is that, again, it's got to be a reflection of the service involved. I mean, there's no connect between what I'm paying for their service and what the service actually costs to provide. Every other segment of the marketplace is like that. The loaf of bread, everything is. So we need to bring that functionality back. So you said, I mean, we're at a key crossroad here, and so much of this is kind of beyond maybe the scope of North Dakota policy making. But I ask you, how can we get this back on a different footing to where? Well,
I think I think we're going to start with one of the things that I think we're committed to doing, and I know Sanford now is committed to doing is sitting around the table with all the stakeholders that we can get, that the right people sit around the table and say, because I'll tell you, Rob, if we were to design a healthcare system today, it probably wouldn't look like what we got.
No, I don't think anybody.
It looked very different, and so
this is what the status quo is something we've backed into over time. Mm-hmm. Nobody sat down and said, "I'm going to plan it this way, and this is how it's going to work." Nobody wanted this. This is just where we're at.
And so I think we've got an opportunity to say, okay, and this may be a little Pollyannish, but if we were to start from zero, how would we design a healthcare system? The payers, the providers, let's all sit down and get some structure to it and see what that looks like, and then we can look at how do we get there. Because, like I said, I'm really confident in the North Dakota legislature that we've got willing, I think, participants among the policymakers. We've got a governor, I think, who'll take an active interest in it. You've got an insurance commissioner who wants to do this. And you've got, I think, hospitals who are in need of if you're not Sanford, you need to do something, right? You need to make a shift in the marketplace to remain competitive. And so I think we got willing participants in the hospital community as well, but it's just going to take time to sit down and do this. And so I'm hopeful we can do something like that. Will we completely turn the whole boat of healthcare? Probably not, but if we can make some progress, that's a good step forward. But to your point about the engagement on the system, a lot of this comes back to too is consumer engagement. And again, it goes back to there's a lack of ability of a consumer to even know what their healthcare costs are. And so the more we can work on that, and that's not something that's going to change overnight, because one, you got to have a consumer who wants to know that, and two, you got to have a system that can provide that in a reasonable manner, and then you got to get those two to meet together and get excited about it. Whereas like when I go buy milk, I can watch the price of milk go up or change over time, and so I know what's happening with that. And not that we'll ever get to healthcare services like buying milk, but if we can get the consumer more engaged and more knowledgeable of what their procedures are.
Yeah.
For example, like if a normal traditional birth costs $35,000 in Fargo and $5,000 in Grand Forks, for some families it may make a hell of a lot of sense to drive that hour north.
Get a hotel room in Grand Forks and have that baby in Grand Forks. Yeah.
Yeah.
I mean, but some of that stuff's tough too, because I've had children, and you kind of want the person delivering the baby to be the same person you had all your appointments with. So some of that's hard. I mean, because I think you made a really good point. We're not going to get medical care to be the same thing as buying milk, because it's not the same thing. Like buying other products, like buying a car can be an elastic thing. If I go out and I can't find the right price, maybe I'll just keep driving the one I have for another year. I can't do that if I need medical care, right? Like I can't, maybe some procedures you can, but for the most part, when you need the hospital, you need the hospital, and that's just it. You don't have time to shop around. But I think what we need to do is I still think what you're saying is really important is to tie, so people can see this is what it's costing you and understand this is what's driving the cost. Because right now that is very opaque. I don't think a lot of people understand at all the factors that go into this is ultimately like you get the notice from your employer that your insurance premium is going up or whatever. All the factors that go into that, right? And it's not your employers. It's there are specific things, and we need to understand what those are.
And we've taken in this country, we've spent the last decade plus, I would say, with a microscope on the insurance industry, and that is by no means to say that the insurance industry is doing it perfect.
Rightfully so. I think rightfully so.
Yeah, absolutely. And so we have taken a deep dive on them, and I'll tell you, it's our job here in the insurance department. We look at their financial books all the time. I mean, we are in their books all the time, and to make sure that they're solvent, make sure that they're not charging overly excessive rates or things like that. I would argue there's nobody on the hospital side that does that. There's no regulator over the hospitals on what that looks like. I mean, most of the hospital regulation is around facilities, making sure you got the this is going to oversimplify, but you got outlets in the right places. You got the right kind of stuff in your buildings to do this. You got the doctors who are qualified, safety,
right?
But when it looks at the financial side of it, there really isn't any oversight. And when you've got a system who is taking a majority of their revenue comes from some government entity, whether that's state or federal, to me there's some issues there, right? I'm not necessarily for having government looking at private business, but if you're in a system where the choices that you're making on the one side of the financial coin are dramatically impacting not only the cost that the government has to pay either through Medicare or Medicaid, or if you're then continue to ask for additional supports, there's got to be a trade-off somewhere to have some discussion about this, because to us anyways, on the insurance side of the world, and we've been looking at this for a while, it almost looks like the budgeting is backwards for a hospital, where it's like, here's what we need to get and here's the prices we've got to set to get there, versus kind of doing it the other way.
It's not like the hospitals don't have some kind of special status too. I mean, Sanford is a nonprofit. If you're gonna ask for those exemptions, or you're gonna ask for those special treatments from the government, maybe you have to accept it's gonna come with some special scrutiny. And I'm saying that as a conservative that doesn't really want the government sticking its nose into everything, but I'm looking at the morass that is our insurance / healthcare system. And I don't know another way. I mean, unless we just want to get back to Everybody just pays the bill for the doctor when you go, like you're buying a hamburger, which I don't think people want either. Everybody's kind of used to the status quo. So finding the political will to move away from employer-based health insurance is going to be difficult because a lot of people are afraid of that. I think if we could do it, it would be great if we could. Yeah. But I think a lot of people are afraid of that change and don't really want it. So if we want to do something about it, what you're talking about kind of seems like the only thing we can do.
Well, I would argue it's we got to at least try, right? I mean, and see where that goes. And to the tax status piece, so I'll give Sanford credit where it's due. So every nonprofit hospital has to have a financial assistance piece that's required to have a nonprofit status. Sanford's financial assistance program is probably the best in the state in terms of access and in terms of allowing people to actually access that. Now, generally, the consumer has to reach out and request that. I'd like them to be a little bit more proactive, but they've got the best system that we've seen in the state. There's some hospitals that I'd argue, well, there's one I'd say in your region that you've essentially got to be, you got to have $600 left in your bank, your bank account. You can't have a car in order to qualify. So you've got to essentially be bankrupt, and then you can qualify for financial assistance.
Or be like a teenager, right?
And so, yeah, so it's like, well, that's not really financial assistance if you're already bankrupt. You've already, the financial assistance is to prevent the bankruptcy, and you're already pushing people into bankruptcy and then saying, okay, we'll
help you. Yeah. Now that you're almost drowned,
that's another area that I want to look at is making sure that these financial assistance programs are actually doing something, because again, that's another piece that the hospitals will always bring forward is we need more because we're paying all this out in bad debt care, in charity care.
Okay.
And you look at the numbers, it's just not accurate.
You could avoid some bad debt maybe if you worked with people a little bit before they got to a point where they can't pay their bills anymore. Like work with them.
You're exactly right. And so those are a few of the areas that we're going to certainly look at. And again, I'm optimistic that I'm hoping there's some renewed interest in this, and I'd encourage anybody who wants to. The healthcare study out there is about a 300-page study. I've got an executive summary is also on our website. It is a fascinating review. It's a 50-state review of kind of health insurance or healthcare costs, and it kind of puts North Dakota in comparison to the rest of the country. And I'll tell you again, I'm not a hospital expert. I know enough to be dangerous, but there's a number of warning signs in there that are concerning to me that we're on a trajectory that we can't maintain. And to me, the next step is it's going to be single payer system.
I was just going to say that to the people out there who are saying, "Hey, Port and Godfread, you guys are supposed to be conservatives and Republicans. What are you talking about all this government intervention?" We're talking about we better fix the status quo or figure out a better status quo, because the alternative is what Bernie Sanders wants, and I don't think any of us want that.
But you can see how it happens, right? Whereas if it's too expensive for employers to provide health insurance because the cost keeps going up, and I'd argue a lot of our small businesses are there.
Yeah.
They'll push people on the individual market, and they'll say we can't provide health coverage, so you've got to go now buy it at healthcare.gov. And oh, by the way, it's really highly subsidized now under the Biden administration.
Right. And so we're gonna get to the point
if a new administration comes in and wants to take those subsidies away, you're essentially giving them an increase.
Right.
And we're eroding that piece away to where government is the only solution, and they're already taking steps that direction, and that's really concerning to me, because if I'm a chamber of commerce, if I'm somewhere, it's going to get to a point where it's like, listen, if the government's going to throw money at the individual market and subsidize that we can save $500 a person and put them into the individual market, and they'll be able to get healthcare cheaper than we can pay it because the government's subsidizing. That's going to be a business decision that's going to come up soon. And then all of a sudden you're breaking that tie of employer-sponsored healthcare that you mentioned, but to go to a government-subsidized healthcare. And then all of a sudden you've got a bunch of people that are receiving a government subsidy for healthcare. And
once we're there, it's a half a step to single payer government insurance, which by the way is
more sense to go Medicare for all.
That cannot be an outcome that companies like Sanford want. I mean, they cannot want that. It's like
I don't think they do.
You look down the road, that's where we're heading, but they don't want to. They're resistant to changing anything.
Yeah, and that's the point that I'm making. That by not willing to come to the table and work on it, you're essentially advocating for your own demise. and that's really frustrating because there's going to reach a time, and I'd argue we're there, where the answer isn't more, and if you keep asking for more, we're gonna all get Medicare for all.
Well, on that happy note, I've used up all 30 minutes that John has given me today, so I really appreciate it, John. Thanks for coming on.
Yeah, happy to do it, Rob. Anytime. Thank you.